everyone. In this video we are going to discuss about renal tubular acidosis. So there are three types of renal tubular acidosis, mainly type 1, type 2 and type 4. So type 1 is distal type because it occurs at the level of distal convoluted tubule. Here there is defective H plus ion secretion at the distal tubule. So since there is defective H plus secretion, it will be more retained. So more retention of H plus will lead to metabolic acidosis. So there will be low serum K plus level. This is because of this chronic acidosis, it is compensated by increase in the sodium resorption in exchange to the potassium excretion. So there will be more potassium excretion leading to hypokalemia. And since there is no H plus secretion into the distal convoluted tubule, the urine cannot be acidified. So there will be alkaline pH of the urine. So this alkaline pH will actually increase the precipitation of calcium phosphate stone formation. This is also actually increased by the increase in the citrate due to acidosis. Because of this acidosis, there will be increase in the citrate, and this will precipitate the calcium phosphate stone formation because of this high pH. So the causes are Sjogren's syndrome and amphotericin B. There will be nephrolithiasis because of this precipitation of calcium phosphate stones. The treatment is bicarbonate and thiazides. So next is type 2. It is also called as proximal type because it occurs at the level of proximal convoluted tubule. So here the defect is defective bicarbonate resorption at the level of proximal convoluted tubule. Here the serum potassium will be low because at the proximal convoluted tubule there will be sodium and sodium resorption along with bicarbonate resorption along with glucose and phosphate, and this has been hampered. So there will be low potassium levels, and there will be urine pH will be initially high but later it will be low, and the causes are Fanconi syndrome, carbonic anhydrase inhibitors. There will be no nephrolithiasis. The treatment is bicarbonate and also potassium. Next is type 4, that is hyperkalemic type. Here it occurs at the level of collecting duct where there is aldosterone secretion, which will aldosterone generally it will secrete potassium and H plus ions, and it will resorb sodium along with water. So whenever there is aldosterone deficiency or resistance, there will be decrease in the sodium resorption and decrease in the potassium secretion in the collecting duct, leading to hyperkalemia. So there will be high serum potassium levels, and urine pH will be low because there is decrease in the H plus secretion, but that is not completely absent as seen in the type 1 type. So there will be some mild acidic pH of urine. The causes are diabetes, AC inhibitors and heparin. There will be no nephrolithiasis here also. Treatment is fludrocortisone and correcting the hyperkalemia. So in type 2, why there is hypokalemia is, in type 2 there is bicarbonaturia because there is low bicarbonate resorption. So bicarbonate urea leading to osmotic diuresis causing volume depletion. This volume depletion will secrete aldosterone. So this aldosterone will resorb both sodium along with water, and it will promote potassium excretion leading to hypokalemia. So in type 1 there is hypokalemia, type 2 hypokalemia. In type 4 there is high potassium levels. Urine pH is high in type 1. It is initially high, later low in type 2. In type 4 it is low, that is mildly acidic. Nephrolithiasis is mainly seen in type 1 only. In type 1 the defect is H plus secretion. Type 2 is bicarbonate resorption defect, and type 4 aldosterone deficiency or resistance. So type 1 is distal type. Here there will be metabolic acidosis because it can't secrete H plus ions, and it is the acid is retained causing metabolic acidosis. In type 2 it is proximal type. Here also metabolic acidosis because it can't resorb bicarbonate ions, bases are lost, so there will be metabolic acidosis. Type 4 it is hypoaldosteronemia. Here also metabolic acidosis occurs because there is decrease in the H plus and K plus potassium excretion, so acid is retained. So in all the three cases there is acid base disturbance, that is metabolic acidosis, normal anion gap. Urine pH will be difference. There is alkaline pH in type 1, in alkaline pH in type 1, and initially high and later low in type 2. There is mild acidic pH of urine in type 4. So this is renal tubular acidosis.